is now going to be done through a small, what's called a burr hole, just a very, very small opening on the top of the head here. We make a small, after all of this so-called targeting is done, we then make a small opening with the patient in sort of a beach chair type posture. Everything is padded and comfortable. And we open up the small opening, and then we place the electrode. At this point, actually we place what's called the microelectrode recording array. These are very, very thin, hair-thin electrodes that we can actually record from the brain while the patient is awake, and we go down and get the signature of the globus pallidus internal segment. The patient is actually awake during this part of the procedure, and we want the patient awake because we want the brain to be active so that we can actually learn in that particular patient what exactly the structure is in the brain. What's interesting is the MRI scan can show you the vicinity, but the microelectrode recording gives you the exact location. After that microelectrode recording, which I'll show some examples in a moment, we then place the so-called macroelectrode, which is the final deep brain stimulation electrode, and test it for side effects and for benefit in the operating room. And that is done again with the patient awake. Then the patient is put to sleep, and we either do the other side in the case of a bilateral procedure, but in any case then we're pretty much done. The patient, everything is closed up. The patient goes for a post-operative CAT scan so that we know exactly that the electrode ended up in the right place without bleeding. And then the patient usually stays overnight and goes home the next day. Approximately 1 week later, we put in the battery under a brief general anesthesia procedure, which involves connecting the electrode itself to the extension wire and to the battery, so-called implantable pulse generator. It's a little dark, probably to be able to see this with the lights on here, but the red circles show the target, which is the globus pallidus internal segment, with the electrodes in place. So you can actually see the electrodes either on a CT scan or a post-operative MRI, and we can see whether or not they're in the correct location. The surgical goal in terms of dystonia is placement of the DBS electrode into what's called the motor territory of the GPI. So even though these structures are actually very small, even within that structure you want to get the electrode into what's called the motor territory, which is the dorsolateral or posterolateral part of this area. If you're too close to what's called the internal capsule, which is that white matter pathway I talked to you about, then you can actually have some motor side effects by stimulation. In other words, as the current spreads, it can actually induce some actual side effects that you don't want. So this is sort of the surgical goal. And the microelectrode recording helps us get there. So as we put this hair-thin electrode down through the brain, we can see that the signature, essentially electrophysiological signature of different areas of the brain as the patient's awake, and when we get to the target structure, the GPI has a very characteristic frequency and amplitude of discharge. One thing that we also know because of the anatomy is that there's a structure called the optic tract, which is just below the GPI, and if the electrode is slightly too deep, then if you stimulate, you can actually cause what are called phosphenes, which are actually visual flashes of light that the patient will experience. And we know at that point that the electrode is deep enough. So there's a variety of interesting anatomical things we can do to make sure that the electrode will end up in the right place. The real art to this, after the surgical implantation, of course, of the electrode and the battery, is the DBS programming. As I mentioned, this is done in the clinic with the neurologists. And it's all non-invasive, so the whole system is healed up, the incisions have healed up, and the neurologist will hold the programmer, which is magnetically active through the skin, over the implantable pulse generator or battery in the chest. And then turn up and down the amplitude and choose the different contacts on the electrode in order to try to treat the patient's symptoms. In the case of dystonia, to try to suppress dystonic movements or postures. And there's a variety of manipulations that can be done, both the amplitude of the current stimulation, but also the shape and size of the electrical field based upon choosing the various contacts on the electrode. And then, of course, using the lowest voltage possible to control the patient's symptoms will maximize the battery life. depending upon the level of stimulation, the battery could last for 2 to 5 years, and then has to be replaced. So the advantages of DBS, especially given compared to the older procedures of lesioning the brain, is that it's adjustable and reversible. So as disease progresses, and this is particularly true in the case of Parkinson's disease, which is a neurodegenerative progressive disorder, the adjustments will need to be made to the stimulation to compensate for disease progression. It is reversible, can be turned on and off, and can be adjusted up and down. And it doesn't lesion the brain, unlike the older procedures. There are potential complications. It's very important up front to recognize that DBS is not without potential complications. Like any type of surgery, bleeding and infection are the two big concerns. It's one thing if you have bleeding, when you have a pancreas operation and there's a little bit of bleeding around your pancreas and they control that, you may have a blood transfusion or something. It's a little bit different when you have bleeding in the brain that can cause a problem. The risk of bleeding from this procedure is 3%. What's amazing about it is if you look at all the hundreds and thousands of patients that have been studied, every center comes up with about 3 to 4% risk of bleeding. The good news, if there is any, is that of those 3%, only a third have basically a bad outcome, which you might call a hemorrhage that would cause a stroke. So it is a 1% overall risk of a very bad outcome, namely a stroke causing neurological deficit. There's basically no risk of death from DBS unless there's a reaction to anesthesia. Infection is about 4%. Hardware malfunction, of course, if you talk to the equipment manufacturer, it doesn't exist. But it does exist, I've seen it. One of the problems, and this is actually interestingly more true with dystonia patients, is that because of the twisting postures in cervical dystonia, there's more erosion of the wires that can go down through the neck. And I've seen that more, it's definitely been seen by many groups more in dystonia patients. So it sometimes requires revision of the wires, which involves a small, short outpatient procedure, which is more of a nuisance factor, but it is important to think about. Stimulation-induced side effects. This is a very interesting area. Everybody's brain is a little bit different. So some people do have idiosyncratic reactions to stimulation. Stimulation-induced depression has been seen, stimulation-induced changes in cognition, meaning thinking. Most people don't have that, or the stimulation can be adjusted so they don't have those side effects. There is an interesting group of patients that develop weight gain with target, especially the GPI. So that's another interesting consideration. Frequent reprogramming is often required. That may not really be a quote-unquote disadvantage of DBS. It's just something that's the reality of the mode of treatment. One thing that's true, and as I come in this later half of my talk towards the studies, what's very interesting with dystonia is that it appears that the benefits actually accrue over time. So it's not as if in the first programming session everybody's immediately better. In fact, it's usually not the case. It's usually the case that there's a mild improvement, and then in the next programming session, there's a mild improvement. And then if you look at these studies when they do, like, for example, 3, 6, 9, and 12 months, patients are always better at 12 months than they were at 3 months. And that's even with excellent programming by experienced neurologists. So nobody exactly knows why. It's very interesting. But the response to stimulation appears to accrue over time. That's something I always tell people, because I don't want them to get frustrated 3 months out that they've had only mild benefit, because they'll have much more benefit if they're an average person. They'll have a much more benefit at 1 year than they will at 3 months.